Great. Thank you so much. And thanks to the organisers for inviting me to this wonderful conference. I've really enjoyed it, and I've enjoyed the discussions and the format. I think it's a really nice pace to the conference. So yeah, I have two affiliations just to flag. I'm Director of AI at the Ellison Institute of Technology, which is in Oxford, but it's not part of the university. It's a separate institute funded by Larry Ellison. And secondly, I'm a Professor of Biostatistics at the University of Oxford. I'm going to talk to you today about a piece of applied research that we did that is, I was hoping it was going to come out by the time, but it hasn't quite. So it's coming out, I think, on Thursday in Nature Medicine. And you'll see this rather odd the kind of title, the kind of that I've put up here is that this is the title that we submitted to Nature Medicine. Reclassification of MS using probabilistic machine learning. And then we got a note from the editors saying they really wanted AI in the title. And I was thinking, well, you know, it really is just probabilistic machine learning. It's not really AI. But I'm not going to retract the paper once it's kind of accepted or close to being accepted. So this is the title, an AI-driven reclassification of MS progression. But realistically, or really, it's just a very careful application of probabilistic machine learning. Hopefully, you'll think it's careful by the end of the talk. So the focus of the study is on MS, which affects around just under 3 million people, an estimate worldwide. So 1 in about 3,000. And its characterization is by physical disability and relapse. And when we came into this, currently, when we came into this analysis, the standard clinical classification is around 3 states. Relapsing, remitting MS, where you have these bursts of deterioration, but you recover from them. And you have a burst of deterioration, but you'll recover. But slowly these recovery times reduce over time, and then it's just gradual progression. But these characterizations, these 3 kind of states, are seen as distinct. And secondly, we're based purely on physical kind of disability. And what we sought to do was to say, well, what's the kind of evidence, what's the data-driven evidence for there being 3 states? Maybe there's more states, maybe there's less. Yeah. So rather than doing a qualitative characterization of the states, is there a quantitative data-driven approach? And in particular, can we use medical imaging, brain imaging, to be able to characterize the intrinsic dimensionality underlying the disease progression? The other thing to note is MS is very heterogeneous. So whilst there are kind of 3 states, some people unfortunately move very rapidly through those, others more slowly. So the current state of the characterization or classification of MS, as I said, are into these 3 states. We've got the relapsing remitting, which is at the beginning, where you have these, as I said, these short bursts, but you recover, and the recovery kind of slowly deteriorates over time, these episodes. The limitations are that they don't take into account any quantitative brain imaging analysis. They're not very predictive of how you will respond to treatment. So being put into one of these 3 stages is not predictive of how you will respond to treatment. The prognostication is coarse, as in it's not a high resolution prognostication. And I think this people have said has kind of hampered the development of treatment, because do you develop treatments for each one of these three classes, or should you put people together? So the goal is to do data-driven reclassification using both clinical information and MRI brain imaging, and to ask questions: how many kind of latent states are there? Can we identify those? I should say this is a collaboration with Novartis and the University of Oxford. And it's to be noted, this is a Nature Reviews from 2018, that there was really kind of a demand for more quantitative approaches. The traditional kind of course descriptions are based on clinical presentations rather than perhaps the kind of underlying disease biology. So through discussions with Novartis, we decided to set up a big study to try and explore this and say, what is the evidence behind those three states? If we go purely data-driven, do we recover those states? Are there other states that we would do? So we put together the largest and most comprehensive clinical trial data set in MS. This involves extracting 34 clinical trials over 20 years. There are around 35,000 patients with around 200,000 brain images, MRI scans for those patients, with about 15 years of follow-up. So we've got about just under 90,000 patient years in this data set. It's a really major task to harmonize this data. It took us 3 years of a data wrangling team to put that data set together. Moreover, so we had to set up a secure research environment with the correct levels of information governance within the University of Oxford. So this is a firewalled research environment where we could put the data in. We had to anonymize the data, so remove patient identification. There's actually in the brain imaging, certain brain images have patient identifiable features. So you apparently get the front of the brain, so the nose and the forehead. So for one of our data wranglers, bless him, spent 3 months going through all of these brain images, identifying if there was identifiable features, and then removing them. At the end of the 3 months, they had to leave the project because they'd had the identifiable. So big thank you to that data wrangler. So we have this very, very large, comprehensive data set. What we wanted to do was to use then, rather than think about these discrete subtypes, can we build a probabilistic model that looked at a continuum, a trajectory of disease progression, rather than 3 states where you're in state 1, and then there's a jump to 2 and 3. And to do that in a kind of a data-driven way, and identify, if we have patients that are on a degeneration trajectory, how many kind of states can we do? Can we identify or clearly identify? And how do patients move through those? So to do this, we used a particular approach in kind of statistical machine learning or computational statistics called probabilistic factor analysis. So we've got a number of measurements on each patient. Actually, we've got a number of summary kind of measurements, around 8 on the patients. So we've got a number that are derived from summary statistics from the brain imaging, like lesion volumes. We've got others about physical tests that the patients have to do. We wanted a generative model for the patient measurements such that we get a likelihood function from the generative model. And also a lot of these measurements are highly correlated. So there's a lot of the kind of the physical measurements that patients do, there's really strong correlation. So you want to take that into account in terms of identifying the kind of driving factors. If you're going to go in and identify subtypes, yeah, it's really important that you take into account the kind of covariance and dependent structures between the measurements. So what a probabilistic factor analysis model looks like is to say that the observed multivariate multiple modalities that you measure on a patient are kind of driven by some lower dimensional kind of latent structure. Yeah, so rather than kind of like, 8 measurements, maybe there are 5 intrinsic dimensionalities to those 8 different measurements. For those of you that work in probabilistic models will know one of the features of a factor analysis model is that it's rotationally invariant. Yeah, which means that you want to code it in a way that identifies certain features. And one interesting thing is a feature called sparsity, which says if we induce sparsity into the model, then we're more likely to pull out kind of more identifiable features. So we used something called a spike and slab prior in Bayesian analysis to try and favor sparse representations in this factor analysis. And we also treat the number of latent variables as unknown. So can we use the data to actually dictate or suggest how many latent dimensions are in the process rather than us putting down and saying, oh, there's 2 or there's 5. And to do that, we used something called a Bayesian non-parametric prior in here. The other aspect that we face is the non-uniform sampling times of patients. So here's the kind of structure that we're looking at. And we use something called a hidden Markov model to do this. So we've got a patient enrolls on the trial. We have a lot of measurements at time 1. But then there might be a big gap until they come in again. Then we'll get some other measurements, and we'll get some other measurements, and so. So this is a non-uniform. We've got a non-uniform visit times between the visits. Now, originally we thought about using what's called a continuous time Markov model. So we said, oh, that's okay. It doesn't matter. Like when they come in, we can just model that as a continuous time. Then we get an observation. Then there's some arbitrary time interval. But when you do that on the dimensionality of the data we've got, the size of the data set, it took about 12 hours to do one run of the model. And that's fine if you've built the model, but it's not fine if you're building the model because you want to touch the data lots of times because there's lots of kind of tweaks to the models or lots of the kind of things that you want to do in the model building. So in order to do that, we discretized the data, so go from a continuous time to a series of discrete intervals, monthly intervals. And when you do that, of course, you introduce a whole load of missingness. So we've got this idea of we've got some unknown latent dimensionality, so that was like unknown number of states. That's the thing we're trying to infer. We've got some things that we've seen, the observations, and then we're treating like if the first patient came in, well, they come in initially, and then the next time they were seen was in month 4, then we've got like 2 missing months. But one of the nice things about the hidden Markov model and these kind of probabilistic factor analysis is that you can, what we call, integrate out the uncertainty in these states. So you can treat that as just missing data and still get the models to run efficiently. So the way that we model the outcomes, we've got 8 measurements per patient, some which are physical, some which are derived out of brain imaging, like the T2 lesion. We've got various amounts of missingness in these different in the different measurements. So like there's one of the physical measurement is a timed 25 feet walk. That's typically has about 1/3 of the data is missing on that. But because we've got a generative model, this probabilistic factor analysis model, that's fine. We can kind of almost impute that through. Once we do this and run this on that large data set, what we get is the following. Is that the model identifies 4 factors that seem to describe the observables, the clinical and the brain imaging derived measurements. And with experts, we've put, these are our labels. So these are subjective labels that we've called them. Here you're going to see the sparsity. I remember I mentioned this about this using a sparse factor analysis model. So this means in the so-called load-in matrix we get zeros, which is really nice for the interpretation. So we see the first factor seems to capture physical disability. And you can see why this is based on the kind of measurements or physical measurements that are taken on the patients. The second factor we call diffuse brain damage, because it's picking up a lot in terms of lesion volumes and brain volume for the patients derived from the brain imaging, as well as a cognition score. There is a relapse, which is just a qualitative yes-no on whether the patient has presented with a relapse. And we can see that that's accounted for by a single factor. This is quite nice because it says, well, this is a variable which is pretty much independent of the other variables and is really informative for prediction. And then finally we got something which we call asymptomatic, which is based on the MRI scan. This is an interesting factor because you would miss this factor if you didn't have the brain imaging. So that drives the factors in the 2 observables. And then the next question is, if we have this as a hidden Markov model, what is the intrinsic number of states that we see within disease progression? And we use something called a BIC, which is a Bayesian information criteria. It's a way of kind of scoring models, particularly useful in nested models where you're kind of increasing the dimensionality. And what we found is that the data suggests that there are kind of 8 underlying states of MS. We're going to cluster them down to kind of 4, essentially. But they're nested, so we've got 8 intrinsic states of MS, which is given by data-driven analysis. These kind of cluster together, so states 1 to 3, if we look at, sorry, I should have said these figures here are the average measurements, the expected measurements of patients that are sitting in those states. So what we can see is in states 1, 2, 3, we have low measurements. Sorry, the bottom one is the kind of lesion and relapse. So we're seeing in states 1 and 2, we're seeing low levels of physical and cognitive impairment. At the other end of the side, in states 6 to 8, we're getting high levels of impairment and high levels of central nervous system damage. And in the middle, we have these kind of transitory states between the turn of 2 between those two extremes. This is what the hidden Markov model looks like. And this is this kind of diagram where the arrows are the transition probabilities that were derived from the data. Gives you a course for the trajectory of patients. So suppose you're starting in state 1. This says with certain probability you will move to state 2. And then if you're in state 2, there's a high probability of going back to 1. There's a small probability of going into 5 from 1. So by modeling these transitions, we get to see how patients on a patient trajectory will move between these states. What's really interesting from this state transition diagram is that you only can move, it only appears that you transition to the high level of impairment through these transitory states. There's no arrow that takes you from 1 into 6 or 7 or 8. So this model models the kind of dynamics of patients. It also suggests that we can cluster them into the kind of 4 clinical states. When we looked at the original classifications that came about that people have traditionally used, these 3 classifications, they're not that well distributed across the states that we see. And what that means is that there's little overlap between the traditional classification of MS and the data-driven classification of MS, which suggests that perhaps there's a misalignment between the original classifications and what's actually happening in the underlying disease biology. So we can label these things as early MS, which is the blue states. We've got this transient, which includes an asymptomatic state, which you only get to see if you've measured statistics from the MRI brain imaging, and then the evolved MS states. We can look at the transitions from the early states through to the evolved states, and we can look at what happens under treatment. So under disease-modifying therapy, when we overlay those patients with the particular, because it was a randomized control trials, this is all derived from randomized control trials, what we can see is that the effect of treatment is to reduce the transition from the early MS states into the transient states. But seems to have little impact in the evolved states. It also, because we have a probabilistic model, we can characterize the evolution and the trajectory of patients through this. So we were really pleased on this, yeah? Well, I mean, it was exciting. We'd spent ages, 3 years putting the data together. We found this, what we thought was really interesting. We submitted it to Nature Medicine, and the reviews came back and they said, we really like it. We'd done cross-validation, we'd done held-out data, yeah, that we'd never used, and then we put it through the model, and they said, we'd really like some external validation. So, it's like we've... and so we thought, well, okay, can we do that? So we were fortunate, we reached out to Roche, which is another big pharmaceutical company, and said, through colleagues, through the MS experts that we had on the panel, and said, look, we've got this model we built, which we think is picking up really interesting kind of classifications and progressions in MS. Do you have data that we could validate it on? And Roche said yes. So some of our team went over to Switzerland, to Roche, to run our models internally within Roche on their data. So this was data that we'd hadn't seen before, hadn't been involved in any of the kind of the cross-validation. And before we went, we did a predefined criteria on how we would assess it. So we didn't want to go over, run the model and then try and, You have to be really careful, of course, in retrospective kind of analysis. So we predefined a number of criteria that we wanted to say, well, if we're going to go and fit the model on external validation data, we want to re-identify the MS dimensions, which are those 4 factors that came out from the sparse factor analysis. We want to rediscover the metastates that we had, these early mild evolving. And we wanted this particular thing, this bottleneck that we thought was really interesting of the relapse and the asymptomatic, which says you only get to the severe states by passing through these 2 intermediate states. So we went to Roche. We had data on like 2,000, just over 2,000 patients from 3 trials. And the model effectively matched what we saw. Not exactly, but subject to kind of sample variability that you would expect that we saw. We did a second external validation, which was we identified a large observational study. This is non-randomized, called MS Path. And we contacted MS Path and got hold of their data, which is about 2,000 people that we hadn't seen before. And the headline is that, again, the model replicated. And again, what we saw was this kind of bottleneck in the transient states. I think we had that in here, yeah. So we found, again, this fact that going from early to late, you pass through these 2 intermediate states. So what does this mean for practical implication for managing the disease? Well, the first thing is that actually getting hold of brain imaging is really important and is missing in the traditional kind of classification. Another thing I just would kind of highlight is it might be for the practical management sufficient to consider just the 2 ends, the early mild evolving and the advanced. Because the transient stage you're not actually kind of in for particularly very long time, although you do pass through it. The other thing that we saw is that the traditional classifications do not map very well onto our states. And that has really important implications for developing treatments. Because it looks like the traditional classifications are not really capturing the heterogeneity. Because ours is purely data-driven, we suspect that it's capturing more of the underlying kind of disease biology. So then there's something very interesting we think about. How can we now explore treatments that target these underlying states and hopefully between the transition probabilities between those. So just to conclude, so the left-hand column is where we started from, the clinical phenotypes of MS, which are based on kind of 2 fairly kind of simple characteristics. People have talked about modifiers of them, but in a qualitative sense. And there were 3 main classes. What our data and modeling suggests is that there are 4 latent dimensions in the observable space. One that captures physical disability, one around brain damage, reserve capacity. Relapse sits on its own as a special unique factor. And there's this interesting asymptomatic disease activity that you would only pick up through brain imaging. There's no modifiers because it's a data-driven model, so it's a dynamic model intrinsically. And we have this idea of a disease continuum where you move within states within early MS and then pass through these kind of transient states, either through a relapse state or through an asymptomatic state before you go to evolved. We see no distinction between the previous secondary progressive and primary progressive MS classifications. Currently, the disease-modifying therapies are effective in keeping you in that early stage, but show little kind of in terms of effect on the transitions afterwards. And we think the model allows you to better prognosticate on individuals because we've got a probabilistic trajectory that we can run for individuals. I'd like to thank everybody on the kind of more statistical side in Oxford, collaborators at Novartis, Roche, whose name I've misspelled there, who were very kind to allow us into their system to check our models, and a group of MS experts. Thank you very much.